Welcome to the deep dive. Today we're tackling hypothyroidism. Uh, Basically, when the thyroid gland, that little engine regulating so much in your body, isn't quite firing on all cylinders.
Exactly.
We're going to explore what an underactive thyroid really means for, your metabolism, growth, and overall well-being.
Yeah, and we know you're aiming for a really solid understanding, especially with exams like the MSRA maybe coming up.
Right.
So think of this as your shortcut. We've kind of distilled a load of revision notes to give you the absolute must-know information.
Our mission today is pretty laser-focused.
Right.
Extracting those key details about hypothyroidism you really need for effective revision. We'll break down the concepts clearly, maybe share some clever mnemonics to help you remember the essentials.
And memory tips, yeah. Things that will make it all stick.
Exactly.
So let's dive straight in. Hypothyroidism, at its core, is an underactive thyroid gland. This means it's just not producing enough of the vital thyroid hormones, primarily T4 and T3. And these hormones are like the body's control center. They regulate pretty much everything from energy levels to how you develop.
And there are two main ways the thyroid can become underactive, right? It's not always like a problem with the gland itself.
Precisely. The vast majority of cases, maybe around 95%, are classified as primary hypothyroidism.
Okay.
This is where the thyroid gland itself is the issue. It's simply not capable of producing enough hormone.
Right.
Then you've got secondary hypothyroidism, much less common, maybe 5%. Here, the problem lies upstream with the pituitary gland.
Oh, okay.
It isn't producing enough thyroid-stimulating hormone, or TSH. That's the signal that tells the thyroid what to do. Think of it like the conductor not signaling the orchestra correctly.
Okay, that makes the distinction really clear. Primary is the thyroid, secondary is the pituitary signal. Got it. Now, let's really get into the weeds maybe and explore the why behind primary hypothyroidism. What are the common causes there?
Right. So when we look at primary hypothyroidism, the main type, it's usually down to an intrinsic issue within the thyroid gland itself. And to help you nail these down for your revision, maybe remember this handy phrase, Hashi drug iodine congenital infiltrate.
Hashi drug iodine congenital infiltrate.
I like that. Okay, let's unpack each part. Hashi.
So Hashi points straight to Hashimoto's thyroiditis.
Right.
This is the most frequent culprit, the big one, behind hypothyroidism.
Right.
It's an autoimmune condition where the body's own immune system mistakenly identifies the thyroid as foreign, leading to its gradual damage. A classic example of, our immune defenses going a bit haywire. It often pops up alongside other autoimmune conditions like type 1 diabetes, Addison's disease, pernicious anemia.
Okay.
And interestingly, it's far more common in women. And sometimes, in its initial stages, the inflamed thyroid can actually temporarily release excess hormone, causing a brief period of overactivity transient thyrotoxicosis before it eventually becomes underactive.
Wow. Okay. Hashimoto's most common, autoimmune. Got it. What's next?
D-drug.
D-drug reminds us of drug-induced hypothyroidism. Yeah, several medications can interfere with the thyroid's ability to function properly.
Like what?
Well, key ones are lithium, amiodarone, even some anti-thyroid drugs like carbimazole, which might seem a bit counterintuitive, as well as certain contrast media and iodides. So clinicians really need to be aware of these potential side effects.
Got it. Certain meds can really throw the thyroid off balance. And iodine.
That stands for dietary iodine deficiency. Now, while it's less common in regions where salt is iodized, like the UK, it remains a really significant cause of hypothyroidism globally, particularly in developing countries where iodine intake might be quite low. This deficiency often leads to the development of a goiter that's an enlargement of the thyroid gland as it tries really hard to compensate.
Right, that makes sense. The thyroid needs iodine to make the hormones.
Yeah.
And we have congenital.
Exactly. Congenital refers to congenital defects. This means babies are born either without a thyroid gland or with a gland that just isn't able to produce thyroid hormones effectively because of an inherent issue, something called dyshormonogenesis.
Okay.
Early detection and treatment are absolutely crucial in these cases for healthy development.
And finally, infiltrate. What's that about?
Infiltrate refers to the thyroid gland being, infiltrated by substances that disrupt its normal tissue and function.
Okay.
Examples include conditions like amyloidosis, where abnormal proteins build up, sarcoidosis, which is an inflammatory disease, and haemochromatosis, where there's an overload of iron in the body.
That mnemonic really breaks down the primary causes nicely. Hashi drug iodine congenital infiltrate. Good one.
Yeah.
Now, what about secondary hypothyroidism? We know that's a pituitary issue.
Yes, secondary hypothyroidism, the rarer form, it originates from the pituitary gland not producing enough TSH, that hormone that stimulates the thyroid.
Right.
This can happen due to an isolated TSH deficiency. Or sometimes it's part of a broader condition called hypopituitarism, where the pituitary isn't producing enough of various hormones.
And what causes that?
Well, it can be caused by things like tumors, neoplasms, infiltrative diseases affecting the pituitary, infections, or even radiotherapy targeted at that area. Less often, hypothalamic disorders like tumors or trauma affecting the hypothalamus can also lead to reduced TSH secretion.
And you also mentioned transient hypothyroidism, which isn't a persistent problem.
Precisely. Transient hypothyroidism can occur, for instance, when someone stops taking medication that was suppressing their thyroid function. Or in the period after giving birth, that's known as postpartum thyroiditis, where the thyroid can become temporarily underactive.
Ah, okay.
Or even as part of the natural course of subacute or chronic thyroiditis, where thyroid function might just dip temporarily before potentially recovering.
Okay, so we covered the whys. Now, who is more likely to actually develop hypothyroidism? What are the key risk factors we should keep in mind for revision?
Yeah, another really important area for your MSRA prep. Let's maybe use another mnemonic to help remember some key risk factors.
Yeah.
Female middle lithium amio hyperfamily auto-age treatment.
All right, female middle lithium amyl hyperfamily auto-age treatment. Let's dissect this one too. Female. That ties in with what we said about Hashimoto's.
Yes, absolutely. Being female is a significant risk factor. Women are much more predisposed to hypothyroidism than men. Middle points to middle age, with the peak incidence generally occurring somewhere between 30 and 50 years old.
And then we have lithium and amio, drugs again.
Exactly. These refer to the medications lithium and amiodarone, both of which have a really well-established link to developing hypothyroidism. In fact, a notable percentage of individuals on lithium who also have antithyroid antibodies can develop it.
Right.
And amiodarone use is also associated with an increased risk, up to 20% in some studies. So it highlights the importance of monitoring thyroid function in patients on these specific drugs.
That's a pretty significant drug-related risk. Okay, what about hyper? That seems odd.
Hyper here indicates having been previously treated for hyperthyroidism and overactive thyroid.
Oh, okay.
Whether that was through radioactive iodine therapy or surgery, these treatments, while effective for the overactive thyroid, can sometimes, lead to an underactive thyroid in the longer term.
Right, so the solution for one thyroid issue can, I guess, sometimes contribute to another one down the line. What about family?
Family underscores the role of genetics and family history. If you have a close relative with thyroid disorders, your own risk of developing hypothyroidism is definitely elevated.
Makes sense.
And auto stands for having other autoimmune diseases, things like type 1 diabetes or rheumatoid arthritis. Because these conditions often sort of cluster together, it suggests a potential predisposition to autoimmune dysfunction in general.
That makes sense. The body's immune system might be, I suppose, more inclined to target its own tissues in multiple ways. And AG.
AG refers to being over the age of 60. The prevalence of hypothyroidism tends to increase with advancing age. And finally, treatment reminds us of previous thyroid surgery or maybe radiation therapy to the neck area for other conditions like certain cancers.
We shouldn't forget iodine deficiency is a major risk factor in some parts of the world.
Absolutely. Iodine deficiency remains a primary risk factor for hypothyroidism in many parts of the world where iodine intake is just insufficient. Very important globally.
So we understand the causes and who's at higher risk. Now let's talk pathophysiology. At a fundamental level, what's actually happening in the body when someone has hypothyroidism? What's the underlying process we need to grasp for revision?
Okay, at its core, the pathophysiology, it involves a reduced production of those critical thyroid hormones, T4 and T3. Remember, these hormones act as the body's metabolic regulator.
Right, the engine.
Exactly. So when their levels drop, it leads to this widespread slowing down of metabolic processes, impacting pretty much all organs and systems. Everything just slows down.
And the mechanism, how this happens, differs between primary and secondary hypothyroidism, doesn't it?
Precisely. In primary hypothyroidism, the issue lies directly within the thyroid gland itself. It's often being damaged or inflamed, frequently due to that autoimmune attack we see in Hashimoto's, or maybe it's been compromised by surgery or radiation.
Okay.
In secondary hypothyroidism, the problem originates higher up in the pituitary gland or maybe even the hypothalamus. This results in insufficient stimulation of a thyroid gland that might otherwise be perfectly healthy. It's like a communication breakdown in the hormonal signaling pathway.
So if someone presents with a collection of symptoms that, could suggest hypothyroidism, what other conditions might be causing similar things? What's the differential diagnosis we should be thinking about?
That's a really important point for clinical reasoning, especially for exams. The symptoms of hypothyroidism can be quite nonspecific, vague.
Yeah, like fatigue, weight gain.
Exactly, and they often overlap with a whole range of other conditions. It's easy to initially mistake them for things like depression, chronic fatigue syndrome, maybe fibromyalgia, anemia, or even other hormonal imbalances like menopause.
So it's definitely not always a straightforward diagnosis based on symptoms alone. Any memory tips to help us differentiate or think about differentials?
Well, I think when faced with these vague symptoms, it's crucial to think broadly.
Hmm.
Consider other common conditions that share similar features. So anything that typically causes significant tiredness, mood changes, or unexplained weight fluctuations
Right.
should prompt you to consider and potentially rule out other possibilities alongside hypothyroidism. It's really about looking at the whole clinical picture, getting the tests done, and not just jumping to conclusions based on one or two symptoms.
Now, let's zoom out a bit. What's the prevalence of hypothyroidism here in the UK? What does the epidemiology tell us?
Yeah, in the UK, the overall prevalence of hypothyroidism is estimated to be around 1 to 2% of the general population.
Okay, so reasonably common.
Reasonably common, yeah. And a really notable feature is the gender difference. It's about 5 to 10 times more common in females compared to males.
Wow, that's quite a difference.
It is. And as we touched on with risk factors, the rates tend to be higher in older age groups.
And what about subclinical hypothyroidism? We hear that term a lot.
Right. Subclinical hypothyroidism. That's where the TSH level is mildly elevated, but the free T4 level is actually still within the normal range. This affects a significant portion of the population, estimated maybe around 5 to 10%.
Okay.
It's worth remembering, though, that these prevalence figures can vary a bit depending on the specific criteria used for diagnosis, the population being studied, and even the geographical location.
Okay, so let's get practical. What are the key clinical features, the signs and symptoms that should really make a clinician suspect hypothyroidism and, prompt further investigation? What might you actually see or hear from a patient?
Well, the clinical features of hypothyroidism are incredibly diverse, and often they develop quite gradually, insidiously.
Right.
Some of the more common symptoms patients report include things like persistent fatigue, unexplained weight gain despite no change in diet or activity, feeling unusually cold even when others are warm, that's cold intolerance, constipation, dry skin, maybe hair loss or thinning hair, muscle weakness or aches, menstrual irregularities in women, feelings of depression or low mood, cognitive impairment like difficulty concentrating or just feeling foggy, forgetfulness.
Okay.
Sometimes a hoarse or deeper voice, reduced libido, and even impaired hearing can occur.
And you got a mnemonic to help us remember those common symptoms for revision. Right?
Yes. A helpful one to recall the common symptoms is fat, cold, constipated, dry, weak, moody, dull.
Fat, cold, constipated, dry, weak, moody, dull. Okay, let's break that down. Fatigue, cold intolerance, constipation, dry skin hair, weak muscles, moody, depressed, and dull, forgetful. That's a great way to remember those key presenting complaints. Now, what about the physical signs a doctor might actually observe during an examination?
Right, the signs. Common signs on examination include dry, coarse, and often cool skin. You might see a puffy appearance, particularly of the face around the eyes, and in the hands and feet, this is known as myxedema.
Myxedema, right?
You might also observe a slower than normal heart rate, so bradycardia. A really characteristic sign is delayed relaxation phase of the deep tendon reflexes, especially the ankle jerk. It hangs there for a bit.
Okay.
And sometimes even carpal tunnel syndrome can be associated. Less commonly, you might find serous cavity effusions like fluid around the heart or lungs, swelling of the eyelids, a noticeably thickened tongue, sometimes diastolic hypertension, and a narrowed pulse pressure.
Those are some important physical findings to look out for. Are there any other, maybe less typical ways hypothyroidism can present? Things we should keep in mind for more complex cases?
Yes, definitely. In more severe or less typical scenarios, hypothyroidism can actually manifest as things like acute kidney injury, elevated cholesterol levels, hypercholesterolemia, an enlarged heart, severe constipation leading to a condition called megacolon, problems with coordination and balance like cerebellar ataxia, psychological disturbances including, rarely, psychosis, or even a more severe neurological state known as encephalopathy. And it's always important to remember those potential associations with other autoimmune conditions. Patients might also have vitiligo, pernicious anemia, Addison's disease, or type 1 diabetes.
And you mentioned eye-related issues earlier.
Yes, hypothyroidism can sometimes cause swelling around the eyes, thinning or loss of the outer third of the eyebrows. It's quite classic. Maybe a feeling of dryness or grittiness in the eyes, and less commonly, protruding eyeballs like in Graves' disease, but milder, and visual disturbances.
Okay.
And finally, we should also be aware of specific severe presentations like myxoedema coma, which is a medical emergency, as well as the typical ways conditions like Hashimoto's, postpartum thyroiditis, and subacute thyroiditis might present, as they can have slightly different features.
Okay, so if a clinician suspects hypothyroidism, based on these clues, the symptoms, the signs, what are the crucial investigations they'll order to confirm the diagnosis and maybe figure out the cause?
Right. The cornerstone of diagnosis really relies on blood tests. The single most sensitive and specific test for primary hypothyroidism is measuring the thyroid-stimulating hormone, or TSH level.
TSH, got it.
In primary hypothyroidism, you'll typically see elevated TSH levels. That's because the pituitary gland is working harder, shouting louder, trying to stimulate an underactive thyroid. It's the body's alarm system saying the thyroid isn't producing enough.
And what about T4, the main thyroid hormone itself?
Free thyroxine, or free T4, is also a key measurement. In overt primary hypothyroidism, where symptoms are pretty clear, the free T4 level will usually be low, confirming that the thyroid isn't actually producing sufficient active hormone.
And when would you check for those thyroid antibodies you mentioned?
Autoantibody testing, specifically looking for anti-thyroid peroxidase, anti-TPO, and anti-thyroglobulin antibodies, can be really helpful in confirming an autoimmune cause, like Hashimoto's. While maybe not always essential for the initial diagnosis of hypothyroidism itself, finding these antibodies gives you valuable information about the underlying reason for the thyroid dysfunction, helps confirm the why.
Are there any other routine blood tests that might be useful in someone suspected of having hypothyroidism?
Well, a full blood count and maybe a fasting blood glucose level are often recommended, particularly when the presenting symptoms are quite nonspecific, like fatigue and weight gain, just to screen for other potential contributing factors or coexisting conditions like anemia or diabetes.
Okay.
In some cases of primary hypothyroidism, you might also see low sodium levels, hyponatremia, or an elevated level of creatine kinase, CK, which is an enzyme found in muscle tissue reflecting muscle involvement.
What about imaging? Like an ultrasound, when might that be needed?
Imaging, like a thyroid ultrasound, might be considered if a patient has an asymmetrical goiter, meaning the thyroid feels unevenly enlarged, or if there are any palpable nodules felt in the gland. This helps assess the size and structure of the thyroid, and, importantly, to rule out any suspicious features that might need further investigation for potential malignancy, although that's rare.
Right.
And just quickly, in newborns with congenital hypothyroidism, ultrasound or scintigraphy, along with other tests like serum thyroglobulin, can help pinpoint the specific cause of the defect.
Let's just clarify the interpretation of those thyroid function tests again. It can sometimes feel a bit, well, counterintuitive.
Yeah.
Any helpful memory tips here?
Absolutely. Try to remember this. In primary hypothyroidism, the problem is with the thyroid itself. So TSH goes up as the pituitary tries harder to stimulate it, and T4 goes down because the thyroid isn't responding properly.
Okay, high TSH, low T4 equals primary.
Exactly. Now, in secondary hypothyroidism, the issue is higher up, with the pituitary not producing enough TSH. So in that case, both TSH and T4 will likely be down or normal. T3 generally follows the lead of T4 in both scenarios.
So high TSH and low T4 strongly suggest a primary thyroid issue. What about a situation where TSH, free T4, and free T3 are all elevated? That sounds weird.
Yeah, that pattern raised TSH along with raised free T4 and T3 is usually indicative of something called thyroid hormone resistance.
Resistance.
Yeah, it's a relatively rare condition where the thyroid is producing plenty of hormone, maybe even too much, but the body's tissues just aren't responding to it normally, so the pituitary keeps pushing out TSH.
I see. And we've covered primary, high TSH, low T4, and secondary, low normal TSH, low T4. That covers most bases.
Pretty much the main patterns you'll see, but it's absolutely crucial to remember these are general patterns. Thyroid function test results should always be interpreted in the context of the individual patient's clinical presentation, their history, medications, everything, by a healthcare professional. It's not just about the numbers.
Definitely. Okay, so we've reached a diagnosis of hypothyroidism. What are the main strategies for actually managing this condition?
Right, management. The cornerstone, the absolute mainstay, is hormone replacement therapy using synthetic thyroid hormone. The most commonly prescribed medication by far is levothyroxine, which is just synthetic T4.
Good, levothyroxine.
The dosage needs to be carefully individualized based on the patient's needs, weight, age, other conditions. And we regularly monitor TSH levels and sometimes free T4 to make sure the dose is optimal and adjusted as necessary over time.
And for primary hypothyroidism, is treatment generally always indicated?
Yes, generally all patients diagnosed with symptomatic primary hypothyroidism are treated. The goals are to alleviate their symptoms and, really importantly, prevent potential long-term complications. Levothyroxine is typically a lifelong therapy for this condition.
What about the initial starting doses of levothyroxine? Are there any general guidelines we should know for revision?
There are some general guidelines, yeah. For younger individuals, say those under 50 or 60 years old who don't have any pre-existing heart conditions, a common starting dose might be around 1.6 micrograms per kilogram of body weight per day.
Okay.
The goal is then to adjust this dose based on follow-up TSH levels to bring them into the normal range, usually over several weeks or months.
And for older patients or those with heart problems?
Right. For older patients, say over 60, or those with known coronary artery disease, we usually start much lower and go slower, typically 25 to 50 micrograms per day to begin with.
Much lower.
Yeah, and then increase it very gradually, maybe every 6 to 8 weeks, while closely monitoring their TSH levels and, crucially, asking about any cardiac symptoms like chest pain or palpitations. Even for subclinical hypothyroidism, where the TSH is just mildly elevated, say above 10, a starting dose of around 1 microgram per kilogram per day might be considered, often starting lower too.
So regular monitoring of thyroid function is absolutely crucial once treatment starts.
Yeah.
What are the potential risks if the levothyroxine dose isn't quite right, if it's too high or too low?
Absolutely critical. We typically check TSH levels about 4 to 6 weeks after starting treatment or making any changes to the dosage. It's really important to avoid both undertreatment, where symptoms just persist, and overtreatment, where the dose is too high. Over-replacement in particular can lead to its own set of problems, like an increased risk of osteoporosis, bone thinning, and atrial fibrillation, that irregular heart rhythm, especially in older individuals. So getting that dose right is key.
What if a patient's TSH levels are actually within the target range on levothyroxine, but they still feel unwell? They continue to experience symptoms suggestive of hypothyroidism. Are there other treatment options?
That's a really tricky area sometimes. In some specific cases, if patients continue to have bothersome symptoms despite achieving a normalized TSH level on levothyroxine alone, a specialist, an endocrinologist, might consider the addition of liothyronine.
That's T3, right?
That's synthetic T3, yes. However, this combination therapy is generally initiated and managed strictly under the guidance of an endocrinologist. It's not routine, as the vast majority of patients with hypothyroidism do respond well to levothyroxine monotherapy.
Okay, so T3 is a specialist thing. When should a patient with hypothyroidism generally be referred to a specialist, an endocrinologist? Are there specific triggers for referral?
Yeah, there are definite times for referral. Urgent referral is warranted if there are concerns about serious complications like suspected myxedema coma, or if secondary hypothyroidism is suspected because that needs investigation of the pituitary and hypothalamus.
Right.
We'd also consider referral for more complex cases, certainly if a woman with hypothyroidism is planning pregnancy or is already pregnant. Also, if symptoms persist despite seemingly appropriate levothyroxine treatment, or if that combination therapy with liothyronine is being considered.
Speaking of pregnancy, how does the management change in pregnant women? That sounds like a really important area for the MSRA.
Oh, hugely important. Management during pregnancy needs particularly close attention, and it's really best done in collaboration with an endocrinologist. Ideally, a woman's thyroid function should be stable and optimized on levothyroxine before she even conceives.
Yeah.
Once pregnancy is confirmed, there are different trimester-specific reference ranges for thyroid function tests because things change physiologically. And it's crucial to check TFTs urgently as soon as pregnancy is confirmed so that the levothyroxine dosage can be adjusted promptly, usually increased, to meet the significantly increased hormonal demands of pregnancy.
The demands go up. Are there any other particular considerations for specific patient groups when starting or adjusting levothyroxine?
Yes, just to reiterate, older patients, individuals with pre-existing cardiac disease, or those with very severe hypothyroidism may need to start on a really low dose of levothyroxine, maybe just 25 micrograms, and have their dose increased very, very gradually.
Okay.
And again, any suspicion of secondary hypothyroidism absolutely necessitates an urgent referral for thorough investigation and management of whatever the underlying pituitary or hypothalamic issue is. And just remember, while liothyronine T3 is available, it's generally reserved for specialist initiation only. Most people are effectively treated with levothyroxine alone.
So thinking long term now. What is the typical outcome for someone diagnosed with hypothyroidism who gets appropriate management? What's the overall prognosis usually like?
Generally, the prognosis for hypothyroidism is actually excellent with proper management and consistent medication adherence.
That's good news.
It is. Most individuals are able to lead completely normal, healthy lives with just regular monitoring of their thyroid function and appropriate adjustments to their levothyroxine dose as needed over the years. For the majority of patients with overt primary hypothyroidism, thyroid hormone replacement therapy is highly effective.
Does it ever go away on its own?
Spontaneous remission is pretty rare in established primary hypothyroidism, especially autoimmune like Hashimoto's. So most people experience a significant improvement in their symptoms and overall well-being with treatment, and only a small proportion continue to have persistent symptoms despite achieving normal TSH levels. But it's important to emphasize that lifelong thyroid hormone replacement is often necessary to maintain this good health.
And conversely, what can happen if hypothyroidism goes untreated or isn't managed effectively? What are the potential complications we need to be aware of?
Yeah, untreated or poorly managed hypothyroidism can unfortunately lead to a range of complications affecting various systems. These can include a significantly reduced quality of life due to that persistent, debilitating fatigue. Also, an increased risk of developing dyslipidemia, abnormal cholesterol levels, metabolic syndrome, coronary heart disease, and even stroke. It can contribute to heart failure over time, infertility in both men and women, and subfertility.
And in pregnancy.
In pregnant women, inadequately treated hypothyroidism is particularly serious. It can lead to complications like miscarriage, anemia, preeclampsia, placental abruption, and adverse outcomes for the baby, including preterm delivery, low birth weight, and potential developmental issues or impaired neurocognitive development. In cases of severe, long-standing overt hypothyroidism, there can be impairments in taste, vision, and hearing, as well as significant cognitive problems. And in very rare extreme situations, that life-threatening condition called myxoedema coma can occur, usually triggered by an infection or other stressor in someone with severe, untreated hypothyroidism.
And just to round that off, it's equally important to avoid over-treating hypothyroidism, isn't it? There are risks with that too.
Absolutely. As we discussed earlier, giving too much levothyroxine, essentially causing artificial hyperthyroidism, carries its own risks, mainly an increased likelihood of developing atrial fibrillation and osteoporosis, which then increases the risk of bone fractures, particularly in older adults. So it really highlights the necessity for that careful monitoring and precise dosage adjustment, finding that sweet spot.
So to sort of bring our deep dive into hypothyroidism to a close, what are the really key messages you want our listeners to take away, especially thinking about their MSRA preparation?
I think the most crucial point to remember is that hypothyroidism is, yes, a relatively common condition, and it has the potential for significant impact on health if missed or poorly managed. However, with a clear understanding of its causes, how it presents clinically, and the principles of effective management, it can be very successfully controlled with thyroid hormone replacement, usually levothyroxine.
Yeah, it really sounds like being able to recognize those often subtle and nonspecific symptoms early on, and understanding the absolutely pivotal role of TSH testing in both diagnosis and monitoring are critical skills for clinicians.
Exactly. Early recognition and appropriate individualized management with levothyroxine generally leads to a very favorable prognosis. It allows the vast majority of individuals to live full and healthy lives.
Well, this has been an incredibly thorough and, I think, really helpful overview of hypothyroidism.
Yeah.
Thank you so much for breaking down all those key aspects for us.
It's a pleasure.
And for those of you listening who want to explore this topic further or access more valuable resources specifically for your MSRA preparation, definitely be sure to check out pastthemsra.com and also freemsra.com. There are some fantastic tools and materials to really support your learning journey.